Good morning, good afternoon, and good evening, esteemed professors, doctors, guests, colleagues, and participants from all over the world. Welcome to a comprehensive look at current updates on thyroid disorders in resource-constrained settings, an international webinar conducted by Global Pediatric Endocrinology and Diabetes and the Arab Society for Pediatric Endocrinology and Diabetes. This international webinar is conducted alongside World Thyroid Day. Before beginning today's webinar, we would like to inform you of the rundown of this webinar. We will begin with a welcoming address from the Vice President of GPED, Dr. Agustini Utari, and Dr. Hussein Al-Safar, the Deputy Chair of the Communication Committee of the Arab Society of Pediatric Endocrinology and Diabetes. This will then be followed by our first presentation by Dr. Rasha Al-Radadi entitled Short and Long-Term Management of Graves' Disease in Resource-Constrained Setting. The second presentation is entitled Pitfalls in the Diagnosis and Management of Congenital Hypothyroidism in Low-Resource Settings by Professor Aman Pulungan. Today's webinar will then be concluded with a discussion session. For the smooth running of today's event, kindly pay attention to the following rules and regulations. Participants are encouraged to have their videos turned on throughout the webinar. Participants should keep their microphones off unless permitted by the moderators. And to obtain a certificate of attendance, participants are required to attend the entire duration of the webinar and fill in a feedback form which will be distributed at the end of the event. To officially open today's webinar, we will now respectfully invite our first speaker to deliver the opening remarks. Without further ado, to the Vice President of GPED, to Dr. Agustini Utari, the time and screen is yours.
Thank you very much, Arneta, for the nice introduction. So good morning, good afternoon, good evening, distinguished colleagues, esteemed guests, and dear friends. It is my great honor and privilege to welcome you today webinars, a comprehensive look at current updates on thyroid disorder in resource-constrained setting, organized in collaboration with the Arab Society for Pediatric Endocrinology and Diabetes. As the Vice President of Global Pediatric Endocrinology and Diabetes, I'm thrilled to see so many dedicated professionals gather here to address a topic pediatric endocrinology community. For this webinar, we have over 550 registered from 51 countries globally. Thank you so much. And since its establishment in 2010, Global Pediatric Endocrinology and Diabetes, or GPED, has been committed to improving the clinical care of children with endocrine disorder and diabetes in resource-limited setting. Our Canadian-based nonprofit organization and charity bring together pediatric endocrinologists, pediatricians, and allied health professionals from around the world. We strive to facilitate collaboration, share knowledge, and implement evidence-based action that prioritize the health and well-being of children with endocrine disorder and diabetes, regardless of their geographic location or economic circumstance. Thyroid disorder poses significant challenges in many parts of the world, especially in resource-constrained settings where access to specialized care and diagnostic tools can be limited. The impact of this disorder on the growth, development, and overall health of children can be profound, making it imperative that we come together to share our expertise, experience, and innovative solutions. Today's webinar is a testament of our collective commitment to advancing knowledge and improving outcomes for children affected by thyroid disorder. We are honored to collaborate with the Arab Society for Pediatric Endocrine and Diabetes, an organization that shares our dedication to enhancing the care of children with endocrine disorder in the Arab world and beyond. Our esteemed speaker today, Professor Aman Pulungan and Dr. Rasa Al-Radadi, bring a wealth of knowledge and experience, and I'm confident that their insight will inspire and equip us with the tools needed to make a difference in the life of the children we serve. I encourage you all to engage actively in the discussion, ask questions, and share your perspective. Thank you as well to Dr. Hussein Al-Safar from ASPED, who has supported us with this collaboration. Together, we can overcome the challenges posed by the thyroid disorder in resource-constrained setting. And thank you for your dedication, your patience, and your commitment to this vital cause. Let us begin this journey of learning and collaboration. Thank you. Thank you, Arnetta.
Thank you, Dr. Agustini, for your opening remarks. I will now invite the next speaker to deliver the next opening address. We are very thrilled to be collaborating with the Arab Society of Pediatric Endocrinology and Diabetes for this webinar. Without further ado, to Dr. Hussein Al-Safar, the time and screen is yours.
Thank you very much, Anita. Thank you very much, GPED, ladies and gentlemen, distinguished guests. Assalamu alaikum wa rahmatullahi wa barakatuh. Peace be upon you all. On behalf of the Arab Society of Pediatric Endocrinology and Diabetes, the ASPED, it's my great pleasure to welcome you all to the joint educational event with the Global Pediatric Endocrinology and Diabetes Society. The ASPED is a leading organization dedicated to advancing the understanding, management, and care of pediatric endocrine disorders and diabetes in the Arab region. Founded with the mission to improve the health and well-being of children and adolescents with these conditions, ASPED plays a crucial role in promoting education, research, and collaboration among healthcare professionals, researchers, and advocates in the field. Today, we gather here with a shared purpose to enhance our understanding, collaboration, and knowledge in the field of pediatric endocrinology. This event brings together experts, professionals, and scholars from around the world. I'm thrilled to know that more than 50 countries' representatives are with us tonight, providing a platform for us to exchange ideas, shared experience, and collectively work towards improving the lives of young patients with endocrine disorders and diabetes. Pediatric endocrinology, as you know, a complex area of healthcare that requires multidisciplinary approach. So by joining hands with the GPED Society, we aim to harness the collective wisdom and expertise of our global community, uniting our efforts to address the unique challenges faced by children and adolescents with endocrine disorders and diabetes. ASPED and GPED societies are dedicated to promoting excellence, advancing research, and advocating for the well-being of young patients with endocrine disorders and diabetes. So together, we strive to provide the highest quality of care and education in these specialized areas of healthcare. I would like to express my sincere gratitude to GPED for their welcoming of the collaboration concept, for their unwavering support and commitment in making this event a reality. It is the start, but it's not the last. So expect that we're going to have more collaboration with this wonderful society, and hopefully we'll see you again in future very soon. So today we have very amazing kind of topic to be discussed with expertise. I'll leave you with that. Thank you very much.
Thank you very much, Dr. Hussein Al-Safar, for your opening remarks. We will now proceed to the next agenda of the webinar. The following agenda of the webinar will be moderated by a very distinguished speaker, and it is my great honor today to formally introduce our our moderator for this webinar. Dr. Agustini Utari is a pediatric endocrinologist from Diponegoro University, Semarang, Indonesia. She graduated as a pediatrician from the Faculty of Medicine, Diponegoro University, and she also holds a master's degree in genetic counseling from Diponegoro University. She did a year of research fellowship on Fragile X syndrome at the Mind Institute at UC Davis, USA. And she also completed her pediatric endocrinology consultant training at the University of Indonesia, Jakarta. She then received her PhD in Diponegoro University in joint collaboration with Radboud at the Netherlands. She's a member of ASPED, ASPE, and she was also a co-chair of APES Clan Equity Working Group, a member of the International Pediatric Association Strategic Advisory Group on NCD, and the Technical Advisory Group of NCD of the Asia Pacific Pediatric Association. Currently, she is the Vice President of GPED, a member of the IPA Program Area on NCD and Mental Health, as well as the National Newborn Screening Committee. Without further ado, to Dr. Agustini, the time and screen is yours.
Thank you again, Arnetta, for arranging this meeting. And I would like to invite our speaker today. The first speaker will be Dr. Rasa Al-Radadi from Taiba University, Saudi Arabia. Dr. Rasa is a consultant of pediatric endocrinology and assistant professor of the pediatric endocrinology at Taiba University in Medina. Dr. Al-Radadi completed her pediatric endocrinology fellowship at Relay Hospital in Indianapolis, USA, a Master of Science in Clinical Research degree in Indianapolis. Dr. Al-Radadi is USA board certified in general pediatric and pediatric endocrinology, also completing her pediatric residency at UIC Chicago, America, USA. She has also completed a research fellowship at George Washington University. A world-renowned expert in pediatric endocrinology, Dr. Al-Radadi has spoken at a number of national and international conferences. Her expertise has also been acknowledged through various honors and awards, such as the Dr. Alam's Award for Research Excellence in 2023 and Best Research Award Presentation Award ASPED Endocrine Academy in 2021. We are very honored to have you here, Dr. Rasa, and so now time is yours.
Thank you, Dr. Agostini, for this nice introduction, and thank you for the committee for the invitations. Peace be upon everybody around the globe. Today, I'm gonna talk about one of my favorite topic, Graves' disease. I see myself as a thyroidologist, and this is one of my favorite topics, so let's go ahead and start. Do you hear me very well?
Yes, doctor, we can hear you.
Okay. So regarding the disclosure, I have nothing to disclose, and we'll be talking briefly about the background of Graves' disease. Then I will touch base on the epidemiology. Then we will discuss the clinical presentation of different diseases of hyperthyroidism that can be as differential diagnosis of Graves' disease. Then we'll be talking about investigations, management, and the challenges that a physician who works in resource-limited setting can face. So as everybody knows that, just let me adjust the slide here. Okay, so as we all know that thyroid disease is a global health problem that can affect really like children, and once it happens, it's really can affect their growth and mental development. So as just to review briefly, like what is Graves' disease? So Graves' disease is an autoimmune disorder that's characterized by presence of antibodies that's against the thyroid tissue, which we call it Graves' hyperthyroidism, and also can come against the ocular tissues. And when it happens, we call it Graves' ophthalmology, and it's very rarely localized in the skin, and patient will present also with pretibial myxedema. And this TSH antibody work as agonist on this receptor and induce excessive thyroid hormone secretion, and also uncouple the thyroid from the pituitary control. So it will be working by itself. And these antibodies can stimulate the thyroid gland by a similar but not really identical signal transduction. So in the eyes, these antibodies stimulate the fibroblast, and expressing the TSH receptor induce the hyaluronan production that potentiated by the crosstalk between this receptor and the insulin-like growth factor receptor. And these all are combined by the retroorbital inflammation and extraocular muscle fiber disruption and tissue edema. And also this receptor stimulates the induction of fibroblasts to be differentiated into adipocyte that result in tissue expansion in the eye. It can be mild or can be very severe and bad and cause blindness. And regarding the inside the cell and histopathology, so it's very important to understand this, because this is where the advanced treatment of thyroid comes. So if you look inside the thyroid gland of patient with Graves' disease, usually they have diffuse follicular cell hyperplasia with varying extent of lymphocyte infiltration inside the thyroid stroma. And these infiltrate consist of T and B lymphocyte, and may form the intrathyroidal germinal center, and that will be as a source of TR antibody producing plasma cell. And also can be found extrathyroidal, and like that what we see sometimes if the patient have persistent thyroid antibodies. So that's come from the extrathyroidal production from the regional bone marrow or lymph node site. Here regarding the prevalence of Graves' disease, and if you look at the map, it can be anywhere from very low prevalence, like 0.1 in the very light red, and the dark red represent 1.25, which is the higher prevalence. This map was taken from this study about global epidemiology of hyperthyroidism and hypothyroidism that was done by Dr. Taylor and his group. And they have really nice table that discuss about like in details about different preference around the world. And unfortunately, not all the studies, they looked at different studies, not all the study reported the exact preference. So if you see in A, that means the preference wasn't reported in that country. But I advise everybody to go and take a look at this. It gives us an idea about the preference. Regarding the presentation of Graves' disease, it can present with CNS manifestation, like changes in the behavior, attention span, and changes in the school performance and anxiety, and also disturbance of the sleep. Also fatigability and some cardiovascular manifestation like increased heart rate, tremor, heat intolerance, and sweating. Also, they can present with gastrointestinal symptoms like weight loss and diarrhea. And kids, sometimes they have goiter, which is symmetrical thyroid enlargement. And sometimes they can associate it with bone manifestation like bone maturation and accelerated growth. And if you like take a look at these symptoms, you notice this is all non-specific symptoms. It can happen with any disease, but if it is come all together, that's very typical presentation of Graves' disease. But sometimes, like in real practice, we see kids, they come with only some of the symptoms. For example, I saw like a 13-year-old who presented to me with diarrhea and weight loss. And she had extensive workup by GI, almost 2 years for diarrhea. After 2 years of extensive workup, they did TFT and found she had Graves' disease. Another patient who was like a 4-year-old who came to my clinic in thyroid crisis. And she had, when I went back to her history, she had 2-year misdiagnosed as ADHD, and she was treated with that. So she had some of the symptoms. She had only behavioral change, attention span, and anxiety and disturbance to sleep in that. So patient can come with any symptoms. So you need to have high index of suspicion. Regarding the ultrasound changes, if you look at the gland, you see that the thyroid gland itself is enlarged with hypoechoic and heterogeneous exotexture and hypervascularity, which is very specific to Graves' disease, the hypervascularity. Here, I recommend like physician who work in the resource limited setting to really understand the differential diagnosis of Graves' disease and how they present. Because the problem and the challenges that physicians in this area that they face, that they don't have the investigation to confirm Graves' disease. So they depend mainly on the clinical feature. So if we take a look at this table, like Hashimoto thyroiditis is one of the very common differential diagnosis of Graves' disease. So patient will have chronic lymphocyte thyroiditis and destruction of the thyroid follicles, causing supraphysiological release of thyroid hormone. Most of the time, this is temporary, not permanent. And this form is milder than Graves' disease and self-limited in contrast to Graves' disease. And if we take a look at the ultrasound of this patient, the differences that in the vascularity. So it's usually either decreased, normal, or increased, not like a Graves' disease where they have hypervascularity. The other differential diagnosis, like infectious diseases, like subacute thyroiditis, which is usually post-viral, and the patient will have tender, firm thyroid and painful manifestation. And if they have bacterial infection, they will have severe pain, fever, and if you take a look at the ultrasound, they will have, in the thyroid lobule, they will have central necrosis. And the other also is one of the very important differential diagnoses is the autonomous functioning nodules. So the patient will present also with milder symptoms than Graves' disease, and they will have asymmetry of the thyroid gland, and they have palpable nodule either by physical exam or nodule that can be seen by ultrasound. Some syndrome also present with hyperthyroidism, like in pediatric, like McCone-Albright syndrome, which is caused by mutation in the GNAS gene. So this patient, if you take a look in the general exam, in their skin, they will have hyperpigmentation, which we call it café au lait macule. And also in the bone, they will have fibrous dysplasia. And also they are prone at different like endocrine disorder, like precocious puberty. And they have typical symptom of hyperthyroidism that's secondary to multinodular toxic goiter because of this stimulation of the receptor by the GNAS mutation. The other also important thing to consider in the differential diagnosis that is not very common, one of the rare disease, that TSH secreting pituitary adenoma. So patient will present with hyperthyroidism plus diffuse goiter, headache, and visual field defect, and also galactorrhea. And this like headache and visual defect galactorrhea, it's unique to the make you think about pituitary adenoma. Other also very rare, but actually it's very difficult to diagnose and treat is the familial non-autoimmune hyperthyroidism, which is genetic disorder. Patient will present with goiter and progressive hyperthyroidism from early life. Also, thyroid hormone resistant. When the patient have inactivation mutation in the thyroid hormone receptor itself, and it's only in the beta subunit. So this inactivation mutation in the beta subunit make the patient have unique feature that mixed between hypo or normal thyroid function and also hyperthyroidism. So it's very difficult to diagnose, but the thing that you need to notice about this patient, they have attention deficit, tachycardia, goiter, and also potential short stature, and they have family history of similar syndrome in the family. And the other like causes of hyperthyroidism, like factitious thyrotoxicosis, if the patient taking a lot of levothyroxine or any thyroid hormones externally, so they will present with symptom of hyperthyroidism, but physically they are normal. The other thing is the iodine-induced hyperthyroidism. So in the history, it's very important to know if the patient was exposed to iodine, if the patient has radioiodine contrast exposure, or has other medications like amiodarone. So if you work in the resource-limited area, you're going to be depending mainly on the clinical presentation of these causes of hyperthyroidism. So it's very important to know the differences between them. Regarding the investigations, so if you have patient with the low or suppressed TSH, the first thing to do, free T4 and free T3. If they are normal, then the patient has subclinical hyperthyroidism. If the free T4 normal and free T3 is high, then the patient have T3 toxicosis. But if they are both elevated, then the patient have offered hyperthyroidism. Here, it's important to do the free T3 because for us, usually for thyroid disorder, we do TSH and free T4 for the cost, especially if you work in a resource-limited area. But if the patient present with hyperthyroidism, then you need to do free T3 also, because we don't want to miss the T3 toxicosis as well. And also, if it is available, it's better to do the TSH receptor antibodies, that to confirm the diagnosis. So if it is positive, that confirms patient has grave disease. If it is negative, then you look at other differential diagnosis. Ultrasound is not in every patient. So if you have a patient with thyroid enlargement that is asymmetry, or you feel the patient has nodules, then you need to do ultrasound. If the patient have nodule more than 2 centimeters, then you do isotope scan. If it is less than 2 centimeters, you don't need to do anything. Serology is efficient. And if the child present with the Graves' disease, and even if it is just suspected, not confirmed, if the patient has really significant symptom, so it's better to start beta blocker, especially if they have tachycardia, muscle weakness, a tremor, and neuropsychological changes. So treatment with beta blocker is very recommended and highly needed to decrease the heart rate and symptom of Graves' disease. And you need to make sure that the patient doesn't have asthma or reactive airway disease. If that's present, then you need to select cardioselective beta blocker, such as atenolol and metoprolol. Here, different choices of beta blocker. So we said it's depend on the clinical situation of the child, if he has reactive airway or disease or not. And also if the patient has psychological or mental or CNS symptoms, it's better to select metoprolol because it's the one that crosses the CNS and the blood-brain barrier. So it's the best one to choose if the patient has CNS manifestation. If the patient in the ICU, so it's better to choose the esmolol. Here about different type of management of conventional treatment of Graves' disease. So we have the antithyroid drugs, radioactive iodine, and surgery. And this antithyroid drug work by the inhibition of iodine exudation and organification, and also by inhibition of iodo-tyrosine coupling, and also by inhibition of the thyroglobulin biosynthesis, and also inhibition of the follicular cell growth. The BTU has extra thing that inhibit also the conversion of T4 to T3. Here, just to show the differences between different type of medications that antithyroid drug, so between the methimazole and BTU. Just to go over it briefly, both they have rapid absorption and they have 100% bioavailability, and the peak serum level of methimazole is 2 hours, but for the BTU is 1 hour. And the half-life for methimazole is almost 8 hours, but for the BTU is 90 minutes. And the duration of action, so the methimazole stay longer for about more than 24 hours. For the BTU, it's only 8 to 12 hours. So this is important to consider, especially if the patient has poor compliance. They both cross the placenta, but the methimazole cross more in the placenta and present in the breast milk. And in terms of illness and the metabolism, so the methimazole gets prolonged with the liver disease. And we expect the normalization of the T3 and T4 will be faster with the methimazole, around 6 weeks, and take about 12 weeks with the BTU. Here about the side effect of the medication, some of them common, about 5%, and some of them rare, about around 1%, and very rare one, less than 1%. So the common one that we see in practice is skin rash, urticaria, arthralgia, and arthritis, fever sometime, and transit mild leukopenia. For rare symptoms, we see like GI symptoms and agranulocytosis. And the very rare one, but we need to be careful about, is like thrombocytopenia, hepatitis, and jaundice. So at baseline, before you start your medication, you need to do CBC, including the differentials, and also liver profiles as a baseline before starting the medications. Then after initiating the medications, you need to do the thyroid function test, like after 2 to 6 weeks to adjust the dose. After that, you can measure it every 4 to 6 weeks. Then once it is stable, you need to do it every 2 to 3 months. Then depend on the severity of the hyperthyroidism and methimazole dose. It can take several months for the elevated thyroid hormone to fall into normal range. There is one thing that I want you to really pay attention, that TSH may remain suppressed for several months after starting therapy and is therefore not good parameter to monitor your patient, like early in the course, the first 6 months. So as the patient becomes euthyroid or hypothyroid, then you need to decrease the dose. If the patient has normal thyroid function, to decrease the dose by 25 to 50%. If the patient has hypothyroidism, then to decrease it by 50%. But if the patient has remain hyperthyroid, you need to increase the dose by 25% or sometime more. So always be guided by the thyroid hormone concentration, not the TSH during the first 6 months. After that, you can monitor the patient by both thyroid function and TSH. So in case if the patient have persistent suppressed thyroid in the presence of normal FT3 or FT4, that means the patient might have elevated FT3. So it's important to do the FT3 as well. So if the patient have persistent low TSH with elevated free T3, that means has T3 thyrotoxicosis. So we need to increase the dose. Because sometimes get missed if you do only TSH free T4 at follow-up. Here regarding the important every time during the follow-up to discuss with the family about the compliance of the medications on a regular basis, and also about the important when to stop the thyroid medication, especially if the patient start to have sore throat, fever, we need to stop the medication, do CBC to check for agranulocytosis. And raise TSH above the normal level despite minimum dose of thyroid medications with normal thyroid antibodies, that means the patient start to be in remission, and then we can start to think about stopping the medications. And always, it's very important to counsel the patient at the beginning to stop immediately the medication and check the CBC once they develop symptoms such as fever, joint pain, or sore throat, or mouth sore, pharyngitis, or fatigue, because could be side effect of the medications. So don't wait until it happens, counsel the patient ahead of time. And that was all about short-term treatment of Graves' disease. How about the long-term goal for the treatment? There is some studies in the literature about excessive weight gain in the patient who are being treated for Graves' disease. And these type of a patient, they get, once they get treated, so the metabolism change from fast metabolism to slow metabolism. So we need to do dietary counseling at the beginning before they start to gain weight. And also we need to maybe counsel to send them to the dietitian. So there always this question that come in our mind as a physician, or also in the family, the family come with this question. for how long should I be treating this patient? And before I consider definitive therapy, which is like radioactive iodine or surgery. This is actually, if you read about it and go to the literature, it is a topic of controversy. So there is retrospective study suggested that chance of remission after 2 years of being on the treatment is low if the patient has one of the following. The patient have large thyroid gland, more than 2.5 times the normal size, or the patient very young, less than 12 years of age, or the ethnicity, if the patient not Caucasian, and also if the patient has elevated thyroid receptor antibody above the normal range, and also at the presentation if the patient has very, very high free T4. And there is one study that was done by Schulman and his group. It was published in 1997 about the autoimmune hyperthyroidism in pre-pubertal children and adolescents. That was a comparison of clinical and biochemical feature at diagnosis, then the response at medical therapy. So they noticed that children, when they treated with this drug and used for 1 to 2 years, the remission rate usually between 20 to 30% at the end of this the 2 year. And it's defined you define the remission as being euthyroid, having like normal thyroid function for 1 year after stopping the medications. The other study that was done by Glaser and his group, it was published in 2008 about predicting the likelihood of remission in children with Graves' disease. It was multi-center and prospective study, and it was in adult, but it showed that remission doesn't occur if it doesn't occur during the first 18 months of therapy. The chance of having remission will be really like low with prolonged therapy. So, and if you read the American Thyroid Association guideline that was published in 2016, they recommend that if the patient doesn't go in remission after the first 2 years of being in the treatment, then we need to discuss and start to think about a definitive treatment, which is radioactive iodine and thyroidectomy. But there is exception. If the patient tolerating low dose of medications, then we might need to extend the period. And this approach, especially like extending the period, is especially useful for children who are very young and not candidate for surgery or radioactive iodine. And individuals who are in prolonged therapy more than 2 years should be re-evaluated every 6 to 12 months when transition to adulthood. And there is one study that actually suggesting the likelihood of remission could be really best predicted about the response of the treatment during the first 3 months of the treatment. So if the patient has a good response, that means or suggesting the patient will have higher likelihood of going to remission. But if you review the 2022 European guidelines, they have a little bit different opinion, which is waiting a little bit longer. So they discuss in the guideline about like when to stop this medication. So they mentioned that treatment duration should be at least for 3 years and potentially like 5 years or longer if the patient was in low like medications, and also if have one of the following criteria, which is older age, female, and Caucasian in terms of ethnicity, and have a smaller goiter size, and mild free T4 at diagnosis or total T4 at diagnosis, and have low level of the thyroid receptor antibodies. And patient have history of other autoimmune disorder other than Graves' disease, and also if the duration of the medication is less. And also they mentioned that patient with the TSH receptor antibody that declined by the median of 90% after 3 years treatment. And patient who relapse and while on like antithyroid medication, then that usually happen within the next 12 months of stopping the medications. So we always need to monitor for relapse.
Dr. Rasha Shori, your time is still left, 2 minutes left.
Okay, so let me go faster. So what are the criteria for definitive treatment while under the treatment? So the total thyroidectomy or radioactive iodine treatment is an option for patients who develop thyroid like medication side effect, like severe neutropenia or significant liver dysfunction. And this treatment may be selected if the patients are unable to report like side effects, like the parent have learning disability or the child, and if they have relapse or they don't have, they want the patient or the family, they don't want further treatment with the drugs. And also if they have a history of poor compliance. So then we can like give them like radioactive iodine as another choice. And we need to be careful if the patient have very high total T4 or free T4. Then these patients will need to be pre-treated with medications and beta blocker until the thyroid function become normal before they proceed with the therapy. And the goal of the therapy to induce hypothyroidism, not only normal thyroid function. Why is that? Because the patient with the lower administration of radioactive iodine, that can be result in residual and partial irritated thyroid tissue, which put them at risk of thyroid cancer. So if the patient have large goiter, they need larger amount of radioactive iodine to become hypothyroid. So if the patient have very large goiter, like more than 80 grams, that we usually measure it by ultrasound, then it's preferred to do surgery than radioactive iodine. Here, if you look at the guideline, they said if the patient less than 5 years, it's better to avoid radioactive iodine because of the risk of the cancer. And this guideline came because of this study. They noticed that if patient less than 5 years, the risk of cancer is higher. And if you look at the relative lifetime risk of cancer, it's 1.96, 1.4, until 5 years, 1.16, then it dropped dramatically. Surgery is acceptable if the patient has less than 5 years, has very like large goiter, and the preferred method is total thyroidectomy. The advantage, there is no recurrent hyperthyroidism, no radiation risk, rapid control, and the patient have no like deterioration of Graves' eye disease. Disadvantage, the scar, the surgery itself, anesthesia, and recurrent nerve palsy, like paralysis, and also postpartum hypoparathyroidism. There are also some complications like hypocalcemia, and that actually get decreased if you give the patient calcitriol 3 days before the surgery. That make the length of stay less and also the hypoglycemia less. But you need to wean the calcitriol about 2 weeks after the surgery. Here, if the patient have eye disease, so if it is mild, you can do any treatment modality, drug, radioactive iodine, or thyroidectomy. If it is moderate to severe but inactive, you can do any treatment modality as well. But if it is active, then the only choice is the medications. And also if the patient have sight threatening, you need to do medication. So the minute that you see the child, the first clinic, the first visit, if you see the child have like Graves' ophthalmopathy, then you need to send your patient to ophthalmology for basic assessment of the eye, because that will guide you in terms of choosing the treatment modalities. Here, it's really nice table in the 2022 guidelines that is better, like it's good or nice to review about the differences between radioactive iodine and surgery. And here about the outcome. So the outcome, either the patient get medication intolerance or non-compliance, then you can start right away the definitive therapy with radioactive iodine and thyroidectomy, or the patient choose from the beginning to have definitive therapy other than medications. And if the patient has persistent hyperthyroidism after 36 months of treatment with positive antibodies, then you have the choice to either to complete with the medication for another 12 months, and then after that to check the antibodies. If it's negative, then you stop. If it's positive, to elect definitive treatment. And the other choice to elect definitive treatment instead of continuous for another 12 months. And if the patient start to have relapse after stopping the treatment, the medications, then you need to choose definitive treatment. This is just advanced management of hyperthyroidism. This is just beyond the scope of our lecture today, but I felt it's nice to go over it quickly. So the medication that we have, either beta lymphocyte immune modulation or TSH receptor signaling or immune modulator TSH peptide. Here just about the challenges that people or physician in the resource limited setting they can face. And this really nice article that was published by Dr. Muhammad Abdullah from Sudan. And he confirmed that really little has been published about hyperthyroidism in children in the resource limited setting due to lack of the facilities and social-cultural factors that actually prevent the international guideline application or make it difficult to apply. And so in his study, he recorded all patients who were diagnosed with grave disease or hyperthyroidism in their facilities, and they found that about 66% presented of this patient present with exophthalmos, and hyperthyroidism was really common in this population, and because of the absence of lab facilities, differentiation between grave disease and Hashimoto thyroiditis sometimes can be challenges and depend mainly on the clinical features. And also they reported that continue the medical treatment for 4 years can increase the remission to 41%. Here another study was published in Pakistan, and it was talking about the modified guideline, the 2016 American Thyroid Association guideline, based on their setting. So they recommended to assess only ALT instead of the whole liver panel for just the cost effectiveness, and also to assess only free T4. And the rationale because of to prioritize the patient finance during monitoring the side effect of these medications. And here, this article from India to discuss the challenges that could a physician working in the resource limited area face. So they address really important topic about the research gap that actually in the resource limited country compared to the well-developed country. So there is a big gap. So finally, just to take home message, physician in resource limited area really face a lot of challenges, and that's in terms of medical management, also in terms of research. Conducting research in resource limited area is not easy. It's very hard because of a lot of missing data, different system, and also charting itself, it sometimes can be challenging. So I think from this lecture and this talk, I would call for a really good collaboration between all physicians in the resource limited area to be able to come up with modified guidelines that are more suitable to our countries. Thank you.
Thank you so much, Dr. Rasa, for the excellent talk. So we will go to the second talk by Professor Aman Pulungan. Professor Aman Pulungan is a professor of pediatric and the executive director of the International Pediatric Association. He is also an immediate past president of the Asia Pacific Pediatric Association, immediate past president of Indonesian Pediatric Society, and past president of the Asia Pacific Pediatric Endocrine Society. With 28 years of experience, he spearheaded diverse diabetes program, including the World Diabetes Foundation, Type 1 Diabetes Initiative, and Changing Diabetes in Children Indonesia. He has also pioneer of newborn screening in Indonesia. Professor Aman, time is yours.
Okay, you see my slide?
Yes.
Okay. Yeah, good evening, good morning, good afternoon. Yeah, Assalamualaikum warahmatullahi wabarakatuh. Thank you for giving me this opportunity to share my presentation. So actually, this is two different topic. Yeah, it's gonna be so wide. Yeah, pitfall in diagnosis and management of congenital hypothyroidism. That's another one point. But the second point, in low resource setting. So pitfalls is another thing. Without low or normal resource, it still can be a problem. So, you know, if I would like to share or to discuss about this, it's going to be, it's not enough for 30 minutes. So we will see how can we combine these two. I think this is really important, especially when the country, you have newborn screening for congenital hypothyroidism. But without that, also this is quite important. We know congenital hypothyroidism is a condition of thyroid hormone deficient present at birth. And one of the most common, you should remember this, one of the most common causes of mental retardation. So the longer CH is undetected and untreated, the lower the IQ. Save the brain, everybody would say that. And the incidence, this is the epidemiology, 1 in 2,000 to 4,000 births, female 2.2 and 1, and increased risk baby with Down syndrome. And you can see it, in China, Thailand, Pakistan, India, Saudi Arabia, Iran, and Israel, and even in US. How about in Indonesia? Well, we just start our newborn screening from nothing to 1.3 million newborn baby every single year. And 1 year in Indonesia, we have 4.8 million baby born. So size of Singapore population every single year. So last year, we already reached 1.3. Hello? Can you hear me?
Yes, no problem.
Okay. So this is our preliminary data in Indonesia. Since we didn't have that screening yet during that time, we have a multi-center study. Yeah, Dr. Agustini part of the study also from her center. So you can see it here, for CH, we have 1 out of 1,200. For CH, it's even higher, but we are not talking about CH here. So probably in Indonesia, since we have 17,000 islands, about 8,000 inhabitants, so many tribes, we have 38 provinces. It could be different probably from other country, but we don't know yet. But this is what's happening in Indonesia. We know the classification. The classification related also to management and related to the low resource, if you want to treat it, and also related to the pitfall. So you have to know that there is a primary hypothyroidism, central one, and peripheral, and also syndromic, and transient congenital hypothyroidism. This transient sometimes could be difficult. So I'm not going to show this is about transient. This is quite difficult, because you have just to follow it, what the transient is. Yeah? And the prevalence of etiology. How could we know that if we don't have ultrasound? We don't have scintigraphy. Ectopic, thyroidic, hypoplastic, dyshomogenesis. And transient maternal, you have it, iron deficiency, iron excess, anti-thyroid medication, and the TRAB globally, 1 in 12,000, United States, 1 in 50,000, Europe, 1 in 100. We don't know in Indonesia because a lot of other things, not available in our government insurance. Higher in country with high maternal iron deficiency, it will be higher. This is happening in some area in Indonesia, in some provinces. For example, in the province where Dr. Agustini come from. Well, this is just for reminding, I'm not gonna repeat the whole thing, what the tertiary, secondary, and primary, but the important thing is 70% of circulating T4 is bound to TBG. I will explain about TBG deficiency later because I will show the case. 20% is bound to transthyretin and less than 5% is bound to albumin, and only free form are bioactive about 0.03% of T4, free T4, and 0.3 for T3. But this is the most important thing. Even though it's really less than 1%, but this is what we need. Yeah, I will show also our study about this. This is our study. Late diagnosis without newborn screening, 96% developmental delay, 72% at intellectual disability, mostly very, very low full IQ scale, below 70. And you can see it, the performance IQ significant associated with delay treatment. And we know that out of this, FT4 is the most important thing to monitor, not TSH. FT4. T4 is okay. But if you have it FT4, you have to use FT4. If you have it both FT4 and TSH, do it both. One example of our patient, almost similar age, born in the same city in Jakarta. The first one did not receive newborn screening. The second one received newborn screening and start treatment after 2 weeks. You can see the IQ 137 and the other one is 124. And see about the growth retardation also. 6 years old, almost 7 years, you can, send it on the lab, just like 1 or 2 years old. The problem is late diagnosis. Late diagnosis would be a problem for congenital hypothyroidism. So, if we have pitfall, it can be problem. So it's really important. You have to follow up any patient with that. So the experience also in our country about newborn screening, I'm still talking about newborn screening. There is still refusal, technical difficulty, and also sampling time difficulty because our geographic about, a lot of island. You can imagine, 17,000 islands, yeah, all the island. And right now we only have 12 centers for newborn screening. So pitfall number 1, confirmatory test versus initiation of treatment. How should you wait? Scintigraphy is the gold standard for congenital hyperthyroidism program. Discovering the etiology is important to determine the prognosis. However, scintigraphy may not be available in low resource setting. In Indonesia, only seven center have this scintigraphy. Yeah. So in 7 or 8 provinces out of 38. So you can imagine 30 other centers that don't have any scintigraphy. Ultrasound is more widely available and should be utilized once the child is diagnosed with congenital hyperthyroidism. However, ultrasound is operator dependent. In low resource setting, there may not be trained health professional. So you have to treat it as soon as possible when you diagnose congenital hyperthyroidism. So this is, as a scintigraphy, you can see, and this is related to prognosis, and also you can tell the parents, about the treatment, how long is the treatment, a lot of things that, we can explain it to the parents about result of the scintigraphy. Normal thyroid, aplasia is quite different. Hypoplasia is another thing. And ectopic, sometimes we have ectopic referred from ENT department, lingual thyroid. So it's not that severe compared to hypoplasia or the thyroid, but still the patient needs treatment. And this is dyshomogenesis. Yeah. When you do it, the scintigraphy, you can tell what's the difference between these two, and also the explanation from the expert from nuclear medicine. They will tell about the result of the scintigraphy. So pitfall number 1, confirmation test versus time of the treatment. While determining definitive diagnosis and degree of severity, it is important to determine prognosis. Treatment should not be delayed due to lack of imaging. B is scintigraphy or ultrasound. Don't wait. Treatment should be initiated when found hypothyroid through biochemical test. Ultrasound is more widely available, but it is operator dependent. And in low research setting, there may not be a trained professional, but if you work in the hospital, you don't have scintigraphy, please do the ultrasound. Ultrasound combined with scintigraphy improve diagnosis accuracy. If you have it both, do it both. But sometimes a lot of centers, they cannot do it, for baby below 1 months. So you can wait until 4 years old. However, treatment should start while waiting for imaging. So you cannot wait for this. Yeah. Pitfall number 2, factor affecting TSH level in CH and BS. Gestational age influence. This is from one of our candidates for consultant in Indonesia, Dr. Hairunisa. It's unpublished yet because I'm one of the examiner for this research. Newborn screening may not be universal about the cutoff. Gestational age influence neonatal TSH level. Higher gestational, similar to higher TSH. Neonatal TSH is lower in premature babies compared to adult baby. Timing of sampling is important. Average TSH level is lower in older neonate. So let's say like in Indonesia, we want to do it after 48 hours of birth. But the thing is, a lot of baby, they have to go home after 24 hours. So the government still let the midwife or the hospital, because of the government insurance, we can take it, after 24 hours. But remember, should be follow-up. You should follow up about the result. Sometimes, it can be false. Yeah? False negative or false positive sometimes. Okay, and gender, time as a sampling, gestational age factors should be put into consideration when interpreting result. Then pitfall number 3. This is case number 3. A well baby born presenting with normal FT4 and TSH, but low T4 during newborn screening. So, in fact, when I was working in a private hospital, at the beginning, before there is a program from the government, we do both T4 and FT4, but it is quite expensive because we do it in private hospital. And during that time, it's not obligation. So it's they can choose it to do it or they not. Yeah. So for this baby, the pediatrician referred to me for congenital hypothyroidism. But finally, I just check everything from 7 months, 2 years. This is TBG deficiency. This is not congenital hypothyroidism. But in fact, by 4 years old, because I told the parents, even though it's really rare, congenital hypothyroid, TBG become hypothyroid, but I still tell the parents, it's still possibility. It's still possibility. There is a case report about them. And then by sometimes 3 months or 6 months, the parents come, we check the FT4 and also FT4 and T4. And you can see it here. T4 is always low, but FT4 in 4 years old, it's become low. So we start treatment for this patient. Pitfall number three, is this a case of congenital hyperthyroidism? Normal FT4 TSH during newborn, sometimes it's not, there is still a possibility of TBG deficiency, maybe 1 in 10,000 or 1 in 50,000, depends on where are you. NBS panel positive for CH is, but is it really CH? Check TBG. TBG for the patient less than 4 microgram per milliliter. So we diagnose, and actually there is no treatment for TBG deficiency, unless they become hypothyroidism. So the treatment, all the CH, we start the treatment 10 to 15 microgram. Infant with severe CH should be treated with higher starting dose 10 to 15. Infant with mild CH, sometimes we treat it with 10. Infant with pre-treatment FT4 within age-specific interval, start even lower, 5 to 10. Premature, the new recommendation is 4 microgram, not 8 anymore. 4 microgram per day, but you have to follow up. Some of them, become transient. Expected course, normal T4 and TSH within 2 weeks. Target TSH, low normal range. Target T4, high normal range. Okay. And monitor and follow up. This is still most important. FT4 and TSH to be evaluated according to age-specific range interval. First treatment goal is to increase circulating thyroid hormone, which will be reflected by normal TSH. First clinical biochemical evaluation should be done 1 to 2 weeks after levothyroxine treatment. Early is starting dose above 50 microgram. Continue to monitor every 2 weeks until normal. Once normal, evaluation frequently can be lower to once in every 1 to 3 months until the age of 12 months. But depends. If you work in the government hospital, they want to do it to give the patient only for 1 month. Yeah, they have to come back every month instead of 3 months. Clinical and biochemical evaluation, 12 months to 3 years, every 2 to 4 months. 3 years to grow completed, 3 to 6 months. Change of LT4 dose, extra evaluation after 4 to 6 weeks. If you change the dose. If there is doubt to patient compliance or abnormal FT4 or TSH, increase evaluation frequency. Compliance is the most important thing. Yeah? You have to know your patient. IQ test, 4 to 5 years old, I think is still recommended. Because we have to know, sometimes we don't know about the compliance. So some of them, even though they say they take the medicine, the IQ is still low because the compliance is bad. Other evaluation, of course, growth, bone age, scintigraphy, if possible. Prognosis of CH, once confirmed, immediate treatment should be started within the first 2 weeks of age. Appropriate global intelligence, severe CH, and pre-treatment T4 level are predictor of advanced cognitive and motor outcome. Thyroid agenesis found to have lower IQ than dyskinesis. Lifelong treatment is needed in cases of thyroid dyskinesis. Other etiologies, challenge test after the age of 3 years to decide if it has resolved. Yeah. But if you don't have capability or you don't have, ultrasound, if you don't have scintigraphy, don't do it. Just give it treatment and follow up with biochemical monitoring FT4 and TSH. Low levothyroxine dose, less than 2 microgram at 3 years old, good indicator of successful discontinuation. So you have to think. If the dose is less than 2 microgram, well, start finding out what's the etiology. Probably this is transient one. If you have ultrasound, you have to do it. If you have scintigraphy, you have to do it. Probably you have to stop the treatment. Yeah. Take home message. Diagnosis and treatment of CH can be a challenge, especially in rural resource setting. Utilize available of resource ultrasound. Save the brain. Time similar the brain. Save the brain. Biochemistry, TSH, FT4 is the criteria to start treatment. While important, imaging should not delay treatment initiation. Not all positive CH MBS result of CH. So when recalling, you have to make sure whether it is CH or not. Yeah. When you do it, there is a screening in your place. It takes time, and after that, you will know what's the pitfall, and you will know how to handle it. Yeah. Normal range TSH and T4, but low or low normal T4. Think of thyroid binding globulin deficiency. So if there is a low or normal T4 and TSH at the beginning and FT4 normal, you start thinking about probably TBG deficiency, maybe the partial or completely. Okay, thank you. Over to you, Dr. Agustini.
Thank you very much, Professor Aman Pulungan, for the excellent presentation. And today, and now it's at the time for discussion. So we have some question here, and we also have some question in when they register this webinar. So this is the first question for Dr. Rasha. How would you treat the hyperthyroid phase of Hashimoto thyroiditis? Dr. Rasha, you can answer the question.
Yes, that's a good question. Actually, in the resource-limited area, sometime at the beginning, it's very hard to differentiate between the Hashimoto thyroiditis and Graves' disease, especially if the patient doesn't have like the Graves' ophthalmopathy. So sometimes if it is mild, you can just to continue to monitor the patient and watch and see. But if it is severe enough, then to protect the patient from like the tachycardia and all of this, so you treat as Graves' disease with the beta blocker and antithyroid medication, whatever you have, like for example, if it is metimazole. So you treat to give him short course of this medication and follow the patient closely. Once the thyroid function normalized, then you can wean gradually the antithyroid medication and repeat the lab again. Usually with the Hashimoto thyroiditis, with the follow-up, it will declare itself and the symptom will resolve. Then the child will start to have the second phase, which is instead of the hyperthyroidism, they start to have the hypothyroidism.
Okay, thank you very much. And the second question, this is from Rania. This is from Professor Aman Pulungan. For congenital hypothyroidism that has been diagnosed late, how should monitoring be conducted? What factors need to be monitored and for how long? And what is the prognosis?
Well, if this is late, above 1 month, I think the prognosis of the IQ is not good. I presented the paper already. So it's still, the golden period is 2 weeks. But in Indonesia, since we are geographically it's not good, the government said, until 1 month. But we still want to do it. The golden treatment is 2 weeks. So if late, well, we cannot save the brain. The prognosis is not good for the brain. But how you do handle the patient, the same thing like I was telling you before. You should start the treatment, the monitoring still, FT4 and TSH. And after that, if this is late treatment, you have to try as soon as possible, if possible, do the ultrasound or scintigraphy. Because this is, we have to know about the prognosis. Because if this is, ectopic, probably the prognosis is still okay. And test IQ after 4 years old. We have responsibility for the patient. This is what I say, to you. I've been doing endocrinology for maybe 30 years or more. So we have responsibility to our patient to explain it to our patient what has been done before, but we have to explain it. This is the problem. They have to face it. if we know that the IQ below 80 or below 100, between 80 to 100, we can tell them how to send the children, what school that they will give the children. So do monitoring, as I was saying before at the presentation, not different. The dose also that, but you have to know the cause etiology because this is late already. And the third one, you have to do the IQ test. Good luck then.
Okay, thank you, Prof. Aman, for clear answer. And this is the next question. This is for Dr. Rasha. How to manage and follow subclinical hyperthyroidism?
Yes, so if the patient has like subclinical hyperthyroidism, which means that the patient has like the like mild symptoms, so the medication or the treatment is not necessary if the patient doesn't have like symptoms of like hyperthyroidism, like tachycardia and the severe symptoms. So I think it's okay to wait and watch and wait and follow the patient.
How about if the subclinical hyperthyroidism, but the thyroid receptor antibody is quite high?
Yes, because
Yeah,
the
still wait
reason,
for them?
because the reason for treatment is for the symptoms itself. So if the patient doesn't have symptoms, just only lab abnormality, and it's easy to follow up, and the patient like good compliance is good. So it's better to watch and wait instead of starting the medication. So we take it case by case based on your patient and the situation of the setting.
Okay, thank you very much. And the next question. Okay, so this is for Prof. Aman. Do we need to hold thyroxine for scintigraphy?
Yes, you have to stop it at least 1 week or 10 days. That's why, if you want to do it, you have already treated the patient. If you want to do scintigraphy, well, I would recommend when you want to stop the medicine, wait until 4 years old. But what I'm doing here, by myself, I will check the IQ first. If the IQ normal, I can stop the treatment and do scintigraphy. But if the IQ low, I don't think I will stop the treatment and then do scintigraphy. Save the brain first.
Okay, thank you very much, Prof. Aman. And the next question, this is for Prof. Aman. What are the barriers to monitoring congenital hypothyroidism in resource-limited setting for lab, draw, consultation, clinic visit, and how does your team address these challenges? Thank you.
We're talking about screening or normal patient? Probably newborn screening, yeah?
Yeah, this is, I think, for normal and for screening, but how to...
Well, for normal, I think they just have to go to the center, all the government hospital. They will get the medicine right now. It's quite easy. It's cheap, and also support by the government insurance, and also the lab. FT4 is DSH is available in all government hospital, but not in the primary healthcare yet, I think. But for all the private all the county hospital, we have 514 county hospital. I think all of them is available. But the problem is right now is to manage the newborn screening because we have 38 provinces and we only have 12 center for newborn screening. So I think Dr. Agustini also know some of them outside of Java sent to her center. And then when recalling, we have to tell the local Ministry of Health, and they have to find the patient. Sometimes the patient changing the mobile phone, something like that. So this is still a problem for us. That's why I just get back from WHO with our Ministry of Health. Yeah, he wants us to have at least 34 center of newborn screening, I think, by this year or maybe next year. Yeah. Still a problem geographically, Dr. Agustini.
Yeah, thank you, Prof. Aman. Yeah, I think in Indonesia nowadays we increasing our newborn screening coverage because of the Ministry of Health, like have a recommendation for all newborn screening have to have a newborn screening for congenital hypothyroidism. So that's why I think then we increase a lot of percentage of newborn screening coverage. And this is for Dr. Rasha. Could we continue to treat the patient on low dose carbimazole if she is responding nicely and experience no side effect for more than 3 to 5 years?
Yeah, this is one of actually hardest answer to hardest question to answer, because this is a lot of controversy in this topic. But if you follow the American guideline, they after 2 years you need to think really about definitive treatment. But if you follow that 2022 European guideline, actually they recommend that to wait longer. Especially if the patient, I think this patient responding and doesn't have any side effect and stable. So I think it doesn't hurt to wait, because in some study that's waiting for 9 years, that increase the remission rate to up to 70%. So as long as you are monitoring your patient and you feel it's very safe, so I think it doesn't hurt to wait. In terms of to continue the same and don't think about definitive treatment until maybe 9 years, then and see the remission rate at that time.
Yeah, thank you so much. Yeah, I think we have a lot of this experience because sometimes a patient don't want to do the definitive therapy. I think we also have the same problem in our country. And this is the second question for you. Are there any difference between management for extrathyroidal manifestation of Graves' disease after total thyroidectomy and before total thyroidectomy?
I don't know. I don't know if I got this. If I understand this question correctly. So they are asking if there is any difference between management of the extrathyroidal manifestation of Graves' disease, which is systemic manifestation, after the total thyroidectomy and before total thyroidectomy. So it's depend on the actually case by case. So some patients to begin with, they have very mild symptoms. They don't have like one of the patients that I have who referred to me with only diarrhea and weight loss. So she didn't have to begin with the whole manifestation of Graves' disease. Some patients they have only the CNS manifestation, which is an anxiety, behavioral changes, and they don't have the other manifestation. So it depends on your patient which manifestation to have.
Okay, thank you very much. And the next question, please. Yeah, I think this one for Prof. Aman. Do you consider treatment for THH lag after 30 days of age despite the upper normal range of pre-T4? If not, what is the frequency of monitoring after that?
No, don't treat. You have to repeat it, 1 month after that, 3 months. No. FT4 is the indicator for the treatment.
Okay, thank you. And the next question for Prof. Aman, if we have a patient with central hypothyroid and already at euthyroid level, how to manage and how to reduce the dose of levothyroxine? Until when we can stop the treatment?
You cannot stop the treatment. And you cannot decrease the dose unless, when the result of the FT4 is increasing, they become hyperthyroid. That's why you can decrease the dose, but not ever decrease the dose. Yeah.
Okay.
Because the target of the treatment, I was telling you before, the FT4 should be, above the point in the middle. But otherwise, don't ever stop the treatment, and also don't decrease the dose.
Okay, thank you so much. And the next question, this is for Dr. Rasha. First, how can we give anti-thyroid drug? Are there any precaution? And second, how to treat side effect of anti-thyroid side effect?
Yes, that's a good question. I think we went over this a little bit during the presentation, and just to clarify more, that's before you start, anti-thyroid medication is the first line treatment for most of the patient, unless if the family elected to do the definitive treatment, or the patient, that based on your assessment, they will have poor compliance, then you go for definitive treatment. So once you decide to do the anti-thyroid medications, so you need to do baseline workup with the CBC and the differentials and liver profile. This is as baseline. Then you monitor and you counsel the patient first about if they develop any sign of fever, joint pain, or sore throat, or mouth ulcer. Then they need to stop the medication and go to the general pediatrician to check the CBC. So if the CBC, it was found that the patient has agranulocytosis in the CBC, then we need to stop the antithyroid medications and to visit the endocrinologist for further assessment. So most of the time it's just a transit, and we can restart the anti-medication again. The side effect is very much as what we discussed before, that some of them common, like the not the agranulocytosis, the fever, some joint pain, skin rashes. This is one of the common thing. Some of them very rare, but once it's happened, it's really severe, like hepatitis, granulocytosis.
Okay.
Yeah, in terms of monitoring, we need to monitor at the beginning at 2 weeks. Then at if it is not stable, to repeat again in 4 to 6 weeks. Then once it's become stable, then you do it every 2 to 3 months. You do the lab, which is the thyroid function test, the TSH 3T4. And if there is concern about elevated 3T3, you can do it.
Okay, thank you so much. And the next question, please. This is for Dr. Rasa. For those has mild to moderate elevation of free T4 and free T3 with no symptom of clinical hyperthyroidism, is there any rule of beta blocker only treatment to avoid unwanted side effect of anti-thyroid medication?
Yes, it's usually it's unusual to see patient with moderate elevation of the hormones without having symptoms. So we need to clarify with the patient. We take really good history about presence of the symptoms. So once they have symptoms, then we need to treat. Regarding the beta blocker, so the reason to start the beta blocker because of the tachycardia, especially if it is more than 100. So we need to start the beta blocker until the heart rate goes down to normal and the lab normalize or become near normal. Then we can stop the beta blocker. But regarding the antithyroid medications, so once you feel the patient have really highly elevated lab plus the symptoms, then I think we have to treat to avoid because what happens if we don't treat this patient, especially if the patient doesn't come to clinic and you are worried that you're gonna miss the patient, then you put the patient at risk of thyroid storm, which we don't want.
Okay, thank you very much, Dr. Rasa. I think this is the next question. What should a doctor at health center located far from hospital do if he finds a positive case of hypothyroidism?
First, treat them as soon as possible, and then if you don't have any training and you don't have any case before like this, try to do telemedicine consultation with the closest or any other pediatric endocrinology in the country. You can get the list from Indonesian Pediatric Society, or you can find me or Dr. Agustini in our Instagram, just direct message. You can consult anytime, right, Dr. Agustini?
Yes,
But
thank
the
you so much.
first thing, don't wait for the treatment. Start the treatment as soon as possible.
Okay, thank you so much.
Okay,
And
and good luck.
yeah, and I think this maybe we will go to the last question. I have encountered a patient born from a mother who was diagnosed with grave disease at the third trimester. The congenital hypothyroid screening and THS level reveal positive result for congenital hypothyroidism, and then followed by thyroxine therapy, 15 microgram every kilograms body weight at the second and fourth week old. Free T4 is always high. Would you please confirm that in transient congenital hypothyroidism, we could taper off the thyroxine therapy quicker, and for how long this transient condition could happen? And after we could stop the therapy, for how long we should monitor the thyroid function?
No, okay. The first one, if the mother is grave disease, antibody positive, the baby could be hyper or hypo or hyperthyroidism. This is the first one. The second one, since the screening reveal congenital hypothyroidism, that's already, right. You do the right thing. You treat the baby as soon as possible. And then the result, hyperthyroid, you have to decrease the dose from 15 microgram per kg, and then you decrease it to 10, and then after that you decrease it again. Yeah, when the dose is reaching about 2 microgram per kg, that means there is no need to treat anymore. But at least you cannot stop the treatment as soon as possible. It depends also, where the patient come. If they come to the government hospital, of course, at least once a month, because the government will cover once a month for the treatment and for the lab. But if they come to the private clinic, why don't you do it? In 2 weeks you can decrease it. It's no problem because it's already hyper. Yeah. Okay.
Okay, thank you so much.
It's quite clear, Dr. Agustini.
Yeah, I think all
But you
clear
have to decrease it.
answer from Dr. Rasa and Professor Aman. So this seminar discussed the management of grave disease and congenital hypothyroidism. And for grave disease treatment options such as antithyroid drug, radioactive iodine therapy, and surgery were explored alongside consideration for managing and monitoring thyroid function. And in congenital hypothyroidism, early detection through newborn screening was emphasized, followed by the hormonal replacement therapy to prevent a developmental delay. The importance of regular monitoring and multidiscipline care for both conditions was highlighted to ensure optimal management and quality of life of the patient. To conclude, I extend my deepest gratitude to our esteemed speaker for sharing their expertise and insight with us today. Additionally, I want to express my appreciation to all participants for their engagement and thoughtful contribution. Your joining today has made this event truly enriching and rewarding. Thank you for your time and dedication. And now, Arneta, I give it the time to you.
Thank you very much,
Wait, Dr. Aldaradi still here?
Yes, still here.
Yeah, send my regards to Dr. Asmadip and Amir Babikar. Dr. Al-Radadi, sends my regards to Dr. Asmadip and Dr. Amir Babikar.
Yes, I will do. Thank you.
Oh,
Thank
doctor
you.
here. Dr. Hussein. Yeah, Dr. Amir still in Riyadh?
Yes.
Okay.
Thank you very much, Dr. Agustini, Professor Aman Pulungan, as well as Dr. Rasha for the very insightful sessions that we've had today. Truly, there's no event that is complete without a photo session. We will now invite our honorable guests, speakers, and moderators to join in for the group photo. To all the participants, kindly turn your videos on. We will take a group photo with all our distinguished speakers and moderators. We will now give a few seconds to wait for our participants to turn their videos on. In the meantime, I will take a photo of the esteemed speakers and moderators. 3, 2, 1. 3, 2, 1. Okay, we will now take a picture with the participants as well. 3, 2, 1. 3, 2, 1. Okay, we still have a lot of participants that are turning their videos on as we speak. So I'll give a few more seconds. 3, 2, 1. 3, 2, 1. Okay, that concludes the photo session of today. So to all participants, kindly fill in the feedback form as detailed on the slides and has been sent via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. Once again, we thank the Arab Society of Pediatric Endocrinology and Diabetes for their incredible collaboration for this webinar. We also extend our warmest round of gratitude and our appreciation to our speakers, Professor Aman Pulungan and Dr. Rasha Al-Radadi and Dr. Agustin Utari as the moderator for all the incredible lessons and insights that we have learned today. Global Pediatric Endocrinology and Diabetes conducts routine webinars as well as other very exciting activities and opportunities for you. We will also be having the first GPED annual meeting coming up this November. Register to become a member of GPED via the GPED website as seen on the slide. To keep yourself up to date, we urge you to follow GPED on our social media platforms as detailed on the slide, as well as to follow the social media platforms of ASPED as well. Once again, warmest round of gratitude to all parties who have made this webinar a great success. Thank you, and we hope to see you at our next webinar.
Okay. Thank you, Aneta.
Thank you
Thank
very
you.
much. Thank you, Dr. Hussein, Dr. Rasa, Prof. Aman, Arneta, and team, and all participants.
Dr. Pulungan, to Dr. Hussein, Dr. Alexi, Dr. Rashid as well. Thank you very much. To all speakers and moderators, you are free to use Zoom.